to do fixation. When the fracture line is through the facet, there is no facet of C1, C2. There is no discussion. It has C1, C2 fixation has to be done. Most important indication when these things happen in old people, most important indication for me for surgery is when there is any kind of neurological deficit, when there is persistent pain, when there is abnormal cord signal, and of course, when there is abnormal movement. So these are my indications. Otherwise, you can, even in old people, you can conserve. But pain is a very significant symptom. And I show you some examples. You see there is a fracture here. There is a fracture here. Quite a complex kind of situation. C1, C2 fixation. See, we have to learn C1, C2, and it can come in handy in various indications at various times. There is a fracture here. Here, in this case, on one side, probably I was not able to put C2 screw, so I have introduced inferior C2-3 fixation like this on the other side. In this case, there is a big fracture here, and the screw was not possible to put like that, probably in this case. So C2-3 fixation here, C1 fixation here, and bone graft in the middle. Other thing is, you must realize that many a times fracture involves the vertebral artery foramen. So you have to be very careful when you are introducing the screw, because vertebral artery can land straight into your picture. This is the fracture, hangman fracture, as you can see. And in this patient, only one screw is going on both sides in the fracture line. And this patient, there is no C1 inclusion in the fracture. When to include, when not to include are little bit controversial issues. Basically, the fracture is here, and if you can fix the fracture line. This is another one. You see there is fracture here. So one screw is here, one screw is here, one screw is here. Three, a combination of fixation because instability here was feared. So what I have done is various permutations and combinations have been done. Here there is a big fracture, vertebral artery foramen, fixation C1, C2. This one is also quite a fracture. Here there are two screws at each along the fracture line. So two screws along the fracture line. This is osteopetrosis, where there is a weakness of bone. This is the patient having hangman fracture, and there was screw fixation like this, C1, C2 fixation on the other side. Odontoid is a very important bone. In my estimation, I have written on several occasions that odontoid process is like the disc in the subaxial spine. And odontoid fractures, I had published my series of 124 cases over the years. And we all know what is odontoid process. This is odontoid process is the brain of movement. These are the facets of C1 and C2. The rickshaw runs on the facets. He is the brain, this is the power. All the muscles move so he is just holding the rickshaw. Otherwise, the movements are by the facets. Odontoid process is like an orchestra conductor. He does not hold any instrument in hand, but he regulates all the movement. He's the brain of all movements. So these are the types of fractures that we had discussed in our article, and there are various types. Here there is a fracture. The most important thing in odontoid fracture is when you suspect instability. When you suspect instability means it is atlantoaxial instability. And when you suspect atlantoaxial instability, do atlantoaxial fixation. In my estimation, doing transcervical odontoid screw fixation, I don't like. I used to do, but I just don't like it. When you think it is unstable, do a solid C1, C2 fixation. Odontoid screws are like semi-final operation. You must, in this area, always do final operation. So there are various kinds of fractures that we had discussed and we had classified. Whenever there is possibility or evidence of instability, like presence of any kind of neurological deficit, presence of persistent pain, presence of cord shadows, and presence of abnormal movements, it means it is unstable. Unstable means atlantoaxial instability, and atlantoaxial stabilization should be done. And that is a very beautiful final kind of surgery. And we have got, as I have shown, several patients with various kinds of acute and chronic type 1, this is a chronic instability, and there is a fixation, C1, C2. So you do once, and that is the final. This operation, as we all know, is a little bit challenging, but it is now quite a, people have understood and doing on a regular basis, and this is the operation when there is odontoid fracture. This is a chronic odontoid fracture. You see some bone formation here. You can do some kind of realignment, but as I have mentioned, more than realignment, instability is the issue. Instability is suspected, and stabilization is the treatment. Whether you want to put these spacers or not, it is a question mark. Nowadays, I don't put any kind of spacers. So various kinds of trauma and this is C1, C2 fixation, type 1, type 2, type 3, we all know. Whether it is type 1, whether it is type 2, whether it is type 3, we have to do fixation of C1, C2, and this is type 3, and the operation is C1, C2 fixation. This is another type 3. The operation is C1, C2 fixation. Fracture of arch of atlas may be a stable fracture, but if there is persistent pain, fixation. Instability, fixation. Any kind of neurological deficit, 100% fixation. And instability means C1, C2 fixation is necessary. So thank you very much, my dear friends. And I'm looking forward to the discussion. Thank you.
Thank you so much, sir, for your enlightening talk. And I would request Dr. Mora, sir, if he's available, to please call in the next speaker and carry forward the program.
You are mute, sir. You are mute.
Sarukhe.
Yes, sir.
I will invite Dr. Praveen Sarukhe for his talk on management of hangman fracture.
Yeah, I'm ready, sir. Thank you. Thank you very much. I would first like to thank Professor Ramani and Jayesh and Apurva. Thank you for being here. And of course, Professor Goel, he has, spoken a lot of nice things. So we'll just straight away go to the management of, the hangman's fracture, which is my talk for the day. So, right. So as sir has already said, yeah. So for hangman's fracture, it's actually by definition bilateral fracture of C2 pars interarticularis. The pars interarticularis is a structure that connects the two articular processes, the superior articular facet and the inferior articular facet of the C2. And this is quite unique because there's weight transmission from anterior to the posterior side, and that is which makes it quite vulnerable to trauma as well. So this is long and it is likely to get fractured. And then the C1 and C2 moves as one unit, whereas the remaining subaxial spine along with the posterior, the arch of the C2 moves as the other unit. Of course, apart from the bony elements involved, there is also the soft tissue, which is very important and which needs to be looked into. So there is some disco-ligamentous injury as well, which gives rise to, makes the subluxation of C2 on C3 possible, and that is what is also a component of the hangman's fracture. So it is not only the bony fracture, but also the subluxation of C2 over the C3. So axial loading, while we talk about the mechanism, whenever there is hyperextension along with axial loading, we have hangman's fracture. Even with hypoflexion, we can have, hangman's fracture. So with hyperextension, as is seen in submental knots of the hanging, we can have posteriorly angulated C2, whereas in hypoflexion, as most of the sports injury, we have anterior angulation of the C2 body over the C3. So based on that, we have classification given by Effendi and then further modified by Levin and Edward as to type 1, where there's minimal translation, type 2, whereas there is translation greater than 3 mm or angulation of the C2 over C3 by about 11 mm or more, and type 3, where the facet of the C2 and C3 actually dislocates as well, along with the C2, C3 subluxation. So that is very important. And this is the area where, type 1, there is no question of surgery. It's not required. Whereas in type 2 and 3, these are unstable. And as Professor Goel said, wherever there's instability, you need to intervene surgically. So that's the most important thing, stabilization. Stabilization is the key. Again, even in hangman's fracture, there's no different from the C1, C2. So this is the classification which I just spoke about. And 25% of the axis fractures are actually Hangman's fracture. Rest of them are all odontoid fractures or type 3 odontoid and some passing to the facets and other things. Many of them have contiguous or non-contiguous injuries associated. And neurological deficit is not very common in these fractures because it's an expansile fracture. Actually, the posterior element and the anterior element, they separate from each other and there is a lot of expansion. So it's seen only in about 6 to 10% of the patients. We have also seen cases where there is fracture of the lamina, but because of the discal ligamentous injury, so soft tissue injury is also as important. So there would be C2, C3 subluxation and picture, which is very similar to the Hangman's. So coming to the type 1 Hangman's, this is the most common form, and most of them do not require any surgical management and they get away with follow. In the type 2, there is variable disruption of the C2, C3 disc. There is the anterior or the posterior longitudinal ligament, ligamentum flavum. There would be some disruption, giving rise to some translation along with that. And in the type 2A, where there is angulation associated with the C2, C3 dislocation. So that is that angular movement is also seen in type 2A, which is quite tricky because traction is actually contraindicated in these particular group. Similarly, where there is subluxation of the C2, C3 facets, you also have complete disruption. And of course, this will require open reduction and fixation. We have atypical Hangman's where there is, it is not an expansile lesion, and you can see that these patients can present with deficits. So type 1, as I said, conservatively, we can get away with it, collar, that is what is required. And type 3, of course, there is open reduction that is required, so surgery is the solution. So the question is about type 2, where operative versus non-operative. That's the thing which most of us would actually ponder upon. And initially, about 2 decades ago, the treatment for type 2, in most of the cases was external stabilization. So halo immobilization, what was seen that in almost 70 to 80% of the cases, with type 2 fractures, if it could be realigned preoperatively, with the pre-traction, it actually fused in majority of the cases. However, in about 22% of the cases, there was failure and required reapplication of the halo. And in patients who required reapplication, it was noted that the angulation was greater than 12 degrees. Of course, halo nowadays, nobody's going to accept it. I'm not going to accept it. And I don't think any of my patients would agree to halo application because of so many complications, skin site infection, loosening, osteomyelitis, brain abscess, and so many other complications. Of course, the mortality and morbidity in elderly with halo vest is quite high. It's almost reaching up to 40 to 60%. So type 2, later on, majority of them started suggesting surgery, and severe angulation, disruption of the disc and inability to maintain alignment was an indication for surgery. Of course, even now, if you look at the overall picture of Hangman's for treatment perspective, you can see that majority of them get away without any surgical management. That is because majority of them are actually type 1. If you look at the healing rates with non-operative treatment, we can see that 100% of them would heal in type 1, whereas if you go to type 2, 2A, and 3, the healing rates are less than 40 to 50%. So that is the group which will require surgery. There's no doubt about it. So if we talk about the systematic review again and all these things, so surgical stabilization again required for type 2A and those with significant dislocation. So if we look at the surgical options for these unstable fractures, we have anterior C2, C3 discectomy and fusion. Posteriorly, we can give, just get away with putting in a transpedicular screw, which Professor Goyal had just shown. And this was also described by Judith. And we can fuse the C2 pedicle screws along with the C3 facets. Of course, when to include C1 and the occipital condyles or occipital squama would depend on a particular case. So this is the anterior fusion. It looks pretty good, reasonably okay. Most of us are quite familiar with this. And there are a lot of papers and publications which suggest that anterior stabilization is a very effective method to treat unstable traumatic spondylolisthesis of the C2. And however, we had complications of transient dysphagia, hoarseness, graft site pain, infection, non-union, and need for additional posterior fixation. Now, this particular thing, non-union and need for additional posterior fixation, again raises the question: is anterior C2C3 approach really a good approach for unstable hangman's fracture? Of course, you can see here the C2, which is quite high up, and the mandible comes in the way. We find it extremely difficult to put in the C2 screws. There is the structures which are at risk: the hypoglossal nerve, the recurrent laryngeal, external carotid pharynx, so on and so forth. Again, this is one of the cases from my own institute, and we can see here that the anterior fixation really didn't work. It appeared that it was okay, but if you look at the realignment, it wasn't there. I'm not sure whether it actually fused and it continued to remain unstable with time, finally requiring a posterior stabilization. So because that this is the main reason for this is it is difficult to oppose the fractured fragments. And the shape of the C2, it's rounded, so it is difficult to put the plate abreast over that. And of course, you cannot really unlock the facets from anterior. It's very difficult. So that came in the posterior C2 pars pedicle screw. You can see that's the pars fracture, and that is the pars intra-articularis, and that is the pedicle. And the screw which can be put across the fracture line would actually fuse the two fractured fragments. Of course, we need to take care of the vertebral artery, which can, in the intraosseous segment along the C2 the vertebral artery is a danger, and we can mobilize it. And that is still a possibility, and we can still get away with the posterior C2 fixation. So all these were the difficulties with navigation. The rate of perforation of the pedicle and into the canal or into the vertebral foramen definitely goes down, but still there's a little bit of risk that needs to be taken into account. So the thing is, simple C2 transpedicle screw was described in about a decade ago. And what was described was this is a motion preserving segment. Like, C2, C3 motion is preserved. So you just fuse the C2, you put in a screw across the pedicle, across the fracture line, and it would just unite with time. But is that the case? Actually, when we looked at our own data, we found that this thing was actually overrated. So we had seen 3 radiological patterns in the long term in these unstable fractures. So this is one case with translation around 4 to 5 millimeters. The transpedicle screws were put in, good reduction, good alignment. Look at what happens after about 3 months. We can see that there is some actually fusion happening at the C3, C2 facets. So the whole purpose of mobility preserve was all defeated. Then we come to the other group where the translation was greater than 8 millimeters. And what we see is that even if this was aligned, a halo was applied for this patient, it didn't work. And finally, we resorted to putting in the transpedicular pars pedicle screws. Finally, what happened after 6 months, we saw that the C2, C3 fused. So basically, nature wants the C2, C3 to be fused in these cases. And we are actually keeping it unstable till that time by just putting in the transpedicular screw. So treating just the fracture or just putting in the pars pedicle screw is actually not the solution. It is ineffective, and we need to improve C3 the fixation. So another example, translation, and we have reduced that, aligned that with simple pars pedicle screws. No, it just fuses. The C2, C3 just fuses with time. So fusion is inevitable. And there was another case where what we noted, another group of patients, where there was translation between 5 to 8 millimeters. Looks pretty okay in the immediate post-op. But after 6 months, there were a lot of osteophytes. The pain persisted, flexion extension. There was C2, C3 instability. You can see the curvature at the C2, C3 the level, and you can see a lot of osteophytes forming there. So actually the pars pedicle screw alone is an overrated thing, and this was published by us. And so came the era of C2, C3 fixation for unstable fractures, and it has been shown to be very effective, solid fusion rates with immediate relief of pain. Biomechanically, 7 specimens were actually studied with hangman's fracture caliber. So anterior plating, C2 pars pedicle screw alone, and C2 pedicle with C2 C3 fixation was again compared. And what they did was pars pedicle screw alone were.
Praveen, you need to get closer to the mic.
Okay, sir. And posterior C2 C3 fixation more effectively stabilizes the hangman's fracture than just anterior cervical plate. So sagittal balance, of course, again the anterior versus posterior, it was found that posterior approach has an advantage.
Not able to
at
hear you.
promoting recovery of the cervical sagittal balance. When we gave the concept of multiplanar realignment for the unstable Hangman's fracture with posterior C2 fusion, and you can see that it is not only in one plane, it again distributes in multiple planes, lateral plane, anteroposterior, rotational plane, and this is an example, and you just put in the the pedicle, pars pedicle screw across the fracture line, realign the fragments and fuse them with the C3, and you can see solid fusion at the end of 3 to 6 months. And this patient had a very good outcome. Another example where you can see significant dislocation in multiple planes and you reduce them, and you can see in the bottom image, this is a post follow-up image at around 6 months, and it is completely fused. Another example. So these are multiple examples of multiplanar realignment that can be done, that can be achieved by the posterior approach. So this was again published, and of course, not every case, at times one is not able to get into the C2 body. Now that is the most important key. You have to get your screws into the C2 body, preferably across the fracture line, and then fuse it along with the C3. So if that is not possible, this is what happens. So you don't have a good fusion, and it will continue to be unstable. So inclusion of the C1, of course, Professor Goel has already spoken about it. So if you have associated atlantoaxial instability, there's no doubt that you have to include the C1. And if you're unable to get your screw properly into the C2, then it is again important you can get away with the C1, C3 fixation, but all that comes with the cost of loss of mobility. So that is also another important thing that needs to be considered and taken into account. If the fracture line passes into the C1 facet or the superior C2 articular facet, it needs to be included. So this was already spoken by Sir. And coming to the pediatric hangmans, I mean, this presentation cannot be complete without that. So occasionally, this looks like a hangman fracture, but actually it is not. It is just a pseudo luxation of the C2 over C3. And this was again published, and you can actually differentiate it by putting in a posterior spinal line. There are sclerotic margins and other signs on the basis of which you can actually differentiate from that. So rigid instrumentation is still possible in patients who are over 10 years. Of course, for younger children, sublaminar wiring has been suggested, but I really don't have any experience with this kind of thing. So I don't know about that. My youngest patient was around 11 years. So to conclude, type 1 hangman's fractures can be managed conservatively. Halo can be tried in type 2 with minimal translation, or you can get away with just collar. Type 2 and type 3 would require surgical intervention. A pars pedicle screw alone is really not effective. The C2 pedicular screw with C2, C3 posterior fixation is the most effective one. Thank you.
Thank you, Praveen. We have bit overshooted the time. Now I'll request our friend Dr. JKBC Parthiban from Coimbatore to speak on management of locked facets.
You able to see my presentation?
No,
No?
not so far.
No?
Yeah.
It's okay?
Yes, it's
Yeah,
okay.
Thank you. Basically, this is the lock facets of the subaxial cervical spine. And the biomechanically is distraction, flexion, and rotation injuries. So when the movement of the neck happens in this fashion, the facets get locked one over the other one. And in fact, this is a natural process of making an unstable situation to a stable situation. At the same time, the patient may be sometimes neurologically stable, and sometimes the patient may be neurologically having a deficit. So this is where the whole problem starts with. And there is always a question, so what on radiology, if you need an MRI to be a mandatory in all lock facets, or do you need to go in for a CT with the 3D reconstruction? These are some points which needs to be answered. The other question is about the traction. Is traction is mandatory in lock facet management? If in traction, should we wait for the reduction to be achieved before taking up for surgery? If trial traction under GA is a good option, particularly when a patient has got a partial neurological deficit, can lock facets be managed without retraction? Is manual manipulation under GA safe? So all these questions comes in everybody's mind. The next problem comes is the approach and the technique. Can all cases be managed with a versatile anterior approach? When to start with the posterior approach? Do we need multiple approaches? What if one approach is contraindicated in a situation? Is manipulative reduction technique is safe, as I said earlier? Does chronic cases need to be approached only from posterior? These are the doubts comes in everybody's mind. Then you started thinking of algorithms. Is there one standard algorithm available to follow in this world? If not, should we have a set of accepted popular algorithms ready for use? With this, I would like to say a few words about the reduction techniques. The most one which is not practiced much by the neurosurgeons is this the open, that is the closed reduction techniques with the halos, and also by the side of the theater or inside the theater with mild sedations. It is very, very dangerous as far as we are concerned. Though there are many reports which says that there are no deficit in 12 patients of this particular case report, but at the same time, there are also being reports where there is worsening of neurological deficits. So it is very difficult to really think whether this need to be done with the close reduction techniques. So the next thing is about the anterior approach, the surgical approaches. As far as the surgical approach is concerned, anterior, posterior, or combined approaches. So this is what we need to know about it. But as far as I'm concerned, that there are a few techniques which we need to understand about the anterior reduction techniques for lock facets. You can see in this picture here, this picture shows there's a convergent screws which are placed through the anterior approach of the vertebral body. When you compress it, you open up this joint. Compress it, open up the joint, and then they push the superior one posteriorly, you do reduce it. You know, this is the best approach. One can always follow this approach. If you're not using the Casper plates, then one can also use this vertebral distractors, but with the same principle. If you have a unilateral facet dislocation, then you need to have a slightly angulated approach for the pins with the Casper. And then when we do the same technique here, it gets dislocated. The facets can come into alignment. All these things are done during surgery. But there is a point which I like to say is that when we put the patient on traction with the patient on a GA, general anesthesia, the muscles are relaxed. Large number of facets which are locked, they get reduced. So many times you get surprised that the facets are already reduced when you put the patient on pulses. And so it is very important to do the radiograph, the C-arm, pre-op, after this positioning, and then after opening. When you see that, then you will have a better idea about the effect of the muscle relaxants over the facets with the tractions, a little bit of traction. So the question of traction, I'll come back again. There are many techniques which are being used. These are some of another technique which is being used here. Here you can put the pins like a Casper, distract it, and then put a screw over here. It automatically goes up like this. So these are some of the techniques which are being used by surgeons. This is from the anterior approach. And we do have techniques which are posterior approach. You can use the Alice forceps. You can rotate it by seeing it directly here. You can see the facets which is locked here. You can unlock this and then fix it up. Similarly, you can also use different instruments to do this. But most of these things are done under GA because the patient is already positioned. Now, my best this one is by drilling the upper aspect of the inferior facet, which is pushed out. And once you do that, automatically you see the reduction coming in. Then you can put a lateral mass fixation. So this is the one of the easiest and the best one as far as I'm concerned. Some surgeons also use a small curette to uplift the facet which is locked, and then you can reduce it. So many techniques are available as far as posterior reduction techniques are concerned. So we have seen the basics techniques of anterior and posterior. Then when you go through the literature, if you see the algorithms, it's very difficult. It is not possible to accept everything, but each one has got some experience over a period of time. All this very popular, this Stellarmans, and then the altered Stellarmans, all these things are waiting one. That is that you wait for these facets to get dislocated facets to get reduced, and then you go to the theater. So in the present generation, in the new situation, it is not so. It is best thing is that to reduce these facets as quick as possible, because it is much easier when you do it earlier. So MRI, when we do it as a routine in our institution, we have some MRI guided algorithms in acute facet lock, whether it is unilateral or bilateral. So you can see here that if you have a significant disc prolapse, if you find it a significant disc prolapse, then you can always try to do with the traction during surgery, minimum traction I'm talking about. I'm not talking about the large number of large kgs of traction. It's just a traction which can hold the spine a little bit, that's all. But then by 2 kgs or 4 kgs, you can increment it. And if the significant disc prolapse, then you can take out the disc fragment. And after that, you can do an anterior discectomy or plus or minus corpectomy if the anterior reduction techniques and all the things which I showed previously, you can use it. And if it is reduced in this case, then you can straight away go for an anterior fusion stabilization. But in case if it is not reduced, after you have done this, if you are not reduced, then you have to think of posterior reduction technique. So you may have to shift the patient the other way, the posteriorly, and then you go ahead with the posterior reduction technique and then do the posterior fusion. And to augment that, you can go for an anterior fusion. That means that you swipe the patient again, and then do the anterior fixation also, which gives a complete global stabilization. The other condition is that if you don't have a prolapsed disc fragments, then you are very safe. Then you can straight away, you can go, if it is reduced, you can always go on anterior fusion, or if it is not there, if it is not reduced, you can go for posterior reduction techniques. So it is very simple. There is a controversy here. How much a disc is considered very dangerous for prolapse? This is more important when the patient is with partial neurological deficit rather than complete neurological deficit, or when a patient is absolutely normal. So we have to be very careful when there is a large disc fragment. Small disc fragments do not a big problem. If you see the literature, there are many surgeons who have done the posterior approach straight away with the disc being prolapsed out. So very surprising, but then I do not do it. I like to do it anterior approach. Now, what happens when the anterior approach is contraindicated? If you ask me what is contraindication, in a trauma, you can have a very large, very severe injury of the neck, or sometimes there will be a severe short neck. In those cases, you cannot go anteriorly. In that cases, then you may need to do posterior reduction techniques. As far as patients which comes very late, apart from this acute fractures, facet dislocations, but if a patient comes to you very late, then you are always under a confusion what to do, because it may be within about 1 month or sometimes 1 year. So we do not know. So most of the surgeons would like to do whether an anterior approach or posterior approach, but we do not know whether there is a fusion has already happened at the facet joint. But indication for the surgery in this condition is pain. But if it is already fused, then you don't need to go in for a surgery. But a pain is an indication or a progressive neurological deficit. So again, we have this, do the MRI. If you have a chronic facet lock, no traction is needed on pre-op in these conditions. But if you do a traction, then you sometimes you can find a reduction happening in very early period. But if you don't have a disc prolapse with MRI, then again, I said that disc prolapse, you go ahead with the anterior discectomy. And if it is reduced there, again, you do the anterior cervical fusion and stabilization.
Arjun, can you make it fast, please?
Yes, if not reduced, then you have to go for posterior reduction. And the same thing what I said prior. Because of the time consumption, I go a little bit faster since the president has made me to go faster. So I follow the same technique. This is the case examples. You can see that in a flexion here, you distract it, reduce, and then fix it anteriorly. This patient is completely neurologically stable, though it looks very bad here, and we were able to reduce it and fix it from anterior. In this case, it's very, very bad, and you can see neurologically worse condition. You find a very big disc prolapse, irreducible, and we could not reduce it in spite that we go anteriorly. We have done anterior, but it was not able to be reduced. So you shift back posteriorly, and then you do this type of turn again and turn again and turn again, anterior, posterior, and then anterior fixation. But as far as one important point I would like to say in this meeting is that the C6, C7, and C7T1 fracture dislocations are very difficult to reduce by weight. So I always like to go posteriorly in these cases. But if there is a disc prolapse anterior, I go anterior, remove the disc prolapse, then come posteriorly, reduce it open, and then fix it up. So these are the contraindications. In summary, I like to finish here. And MRI is mandatory in the management. Is it a mandatory? Yes. Significance of prolapsed disc material can be assessed to decide on the approach. 3D reconstruction is better for understanding the surgical anatomy. So that will be very good for the surgeon. As far as the traction is concerned, the traction help in immobilizing the unstable segment and may help in unlocking. If reduction get achieved prior general anesthesia, it is good. If not reduction, then may get achieved after GA, positioning and during surgery is very good. So is there a trial traction under GA good option? No, not safe at all. I do not consider this as very safe. These are the important point as far as the traction is concerned. Most of the surgeries can be done through anterior approach. In most, only few cases need posterior approach. In this, as far as these algorithms are concerned, there is no one standard algorithm is available so far. And if you ask me to form a new algorithm, then we should form one with an algorithm which is associated with MRI. Thank you very much.
Thank you. Now I request Dr. Vivek Joseph to present cervical dorsal junction fractures. Dr. Vivek Joseph, please.
Dr. Vivek, you are on mute, I think.
Yeah.
Thank you. Sorry.
Yeah. Please carry on.
Okay, thank you, sir, and thank you, Dr. Ramani and other senior colleagues. Dr. Jayant had suggested this topic, and I know we are running out of time, so I will be very brief and stick to what my thoughts are and my experience with this problem region fractures. So the definition for this region is C7 to T3, and it forms about 2% to 9% of cervical spine injuries. Now the approach is, of course, tailored to the surgeon preference. I'm sure everybody here will have their own techniques on dealing with this problem. But usually this is a 3-column injury, and biomechanical studies have indicated that it's probably better to do both anterior and posterior fixation for these fractures. So what are the problems with these fractures? One is, it is commonly missed, especially in unconscious patients. Secondly is that traction. You can't really see that region on a plain X-ray or fluoro to know if your traction is working or not. Though up to 60 kgs of traction has been suggested in the literature. The other problem is that in any dislocation, it is the lower body which compresses the cord, and to decompress the lower body in this region is difficult. Because the access is limited, the thoracic kyphosis and the great vessels here, they limit the way you can approach this region compared to, say, the mid-cervical region. So to reach this region, you have the low cervical approach, which is essentially the same as the anterior cervical approach, but at a lower level, or going transmanubrium or doing a thoracotomy. It is difficult to put, is my pointer seen?
No.
No.
Pointer is not seen, huh?
Yes, your pointer is visible.
Your mouse is being seen. Yes, sir.
Okay. So it is difficult to put screws here. If you put a plate here, it's difficult to get this perpendicular trajectory to this body. It's not easy to put screws there. Now, posterior approach, the posterior approach usually is lateral cervical mass screws along with upper thoracic pedicle screws. Now, again, in children or, others also, people may not be comfortable with putting pedicle screws in the upper thoracic region. So that also is the problem. So this is our experience over about 10 years, 7 patients, most of them males, wide age group. Time to hospital arrival from trauma is ranging from immediately to 365 days. Most of them were in a good Asia grade. Surprisingly, probably the others would not have reached hospital. That's the other way to look at it. Follow-up, though, was not great. I could get follow-up in only 4 of the 7 patients. Fall from height was the most common mechanism. What happened here? Okay. Now, patients, 4 who were followed up, they had the same uric grade or they improved. So just to quickly go through the different types of surgery done. So this is a Asia grade D injury. He is presented immediately. He's got complete C7 T1 spondyloptosis. Okay, and as mentioned earlier, you can't really see that region on a plain X-ray. So we did a C7 and T1 central corpectomy. Okay, C7 and T1 central corpectomy. Put only iliac crest autograft and then did a C5 to T3 instrumented fusion from behind. And good follow-up, he is fused well. Next case is a patient, 73-year-old with a stiff cervical spine. So he had undergone a cervical laminectomy. And post cervical laminectomy, he had a fall and he came to us 5 days post-trauma. Again, C7T1 spondyloptosis, Asia D. So it's clear that these 3 bodies have to come out. So if you do that, then you're left with a long defect. And for these kind of long defects, fibula graft will be better than your iliac crest. Just to show that post-traction, you can see that there is some widening of this space here. So that's what we did. We did a fibula graft And posteriorly, we have used cervical lateral mass screws above and hooks below. And these are transverse process hooks. And laminectomy was also done. Okay, now this is a 45-year-old who presented one day after trauma with a C7 fracture and C6-7 subluxation. I mean, it doesn't look so on the MRI, but the CT shows it. So what we did here was a C6-7 corpectomy with iliac crest graft, followed by C5 to T1 posterior interspinous cable. Now, this is not a good idea because the cable will not have the strength to hold across the cervicodorsal junction, especially long levels. It's a 2-level corpectomy. So after 1 month, sure enough, the graft has failed and it has prolapsed anteriorly. But interspinous wiring is not, a cable is not a bad option as seen in this case, where we did a single level corpectomy and then the cable. So since it's a small section fusion, it has worked. This is a 10-year-old child who presented after a fall with these facetal fractures and this kind of a kyphosis. I have a feeling this is probably, there must be congenital problem who presented with a fracture resulting in this cord contusion here. So we did a C6-7 corpectomy with iliac crest graft and then posterior instrumentation using cervical lateral mass screws and thoracic hooks because the pedicles were very small in this child. So conclusion, this is a difficult region, anterior decompression. I prefer using uninstrumented bone graft because it is a little difficult to try and put a plate. Other option is to put a buttress plate where the screws are only put on top, on the top body, and the plate will extend across the cage or graft or whatever you put and sit on the lower intact vertebral body. Posterior fixation options are cervical lateral mass screw with upper thoracic pedicle screws or hooks. Hooks, you have a variety of hooks. Pedicle hooks are there, transverse process hooks are there, laminar hooks are there. Interspinous cable must be used. If you're using it alone, you have to be very careful. And of course, the clinical outcome will depend on the Asia graded presentation. Thank you, sir.
Thank you, Dr. Joseph, for your kind presentation. Finished in time.
So I guess Dr. Moda has out of network. So would like to request Dr. Muthukumar sir to start the presentation.
My slides are visible?
Yes, sir.
So at the outset, let me thank Professor Ramani, Dr. Jayesh and Apurva for this opportunity to share some of my thoughts on this particular subject. I will have a 8-minute PowerPoint presentation followed by a short 2-minute video. Now, generally I use this I have been asked to talk on transfat fusion for the cervical spine. Generally use it for degenerative cervical myelopathy due to either CSM and or OPLL. When there is a preserved cervical lordosis or when the alignment is neutral or when there is an associated instability, especially when the degenerative cervical pathology has it's 3 or more levels, or it is used as a part of a 360-degree fusion. It is supposed generally, as all of us do, posterior decompressive procedures are generally not used for irreducible patients with irreducible kyphosis. And with the patient morphology is such that if the patient has a very short neck, and if I have to instrument the C3, C4 level, I generally don't choose this particular method because it is very difficult to get the necessary angle to insert the screw, which we'll be able to see as we proceed later. Now, generally, the preoperative evaluation is extremely important plain radiograph because we need to know the cervical alignment. The cervical alignment should not be a fixed kyphosis. And this procedure can be combined either with transfascial fusion can be combined either with a laminectomy or with a laminoplasty. Doing a laminoplasty along with the lateral mass fixation will be difficult because in lateral mass fixation, the tulip head of the screw will be directed medially. So you won't be able to open the laminar door significantly. And as we shall be seeing later in this presentation, because the implant profile of this particular system is very low, it is possible to combine it with the laminoplasty. And it's also possible to do this procedure as a part of a 360-degree fusion. Now, generally, this is not a new technique. Way back in 1972, Roy Camel introduced this technique. For some reason, it did not become very popular. And in 2006, in Journal of Neurosurgery, Masakazu Takayasu, at the time working in Nagaya, introduced this particular technique. And Delcanto's technique was introduced subsequently, but Delcanto published this technique only in a cadaveric study, not in a clinical case series. I adopted these two particular techniques for the first few patients, and I ended up fracturing a lot of facets. Then I studied the post-op CT scans and developed a new entry point and angulation, which we published in ACTA in 2013. And this is the entry point and screw trajectory. On the left side is the Takayasu's technique, where the entry point is in the middle of the lateral mass. On the right side is the Delcanto technique, where it is in the middle but laterally angulated, just 2 millimeters below the middle of the lateral mass, laterally angulated. And as I shall be showing later, these two techniques have certain disadvantages. And this is our technique we published as a How I Do It article in ACTA in 2013, 10 years ago. And the entry point is 2 millimeters above this is the middle of the lateral mass. The entry point is 2 millimeters above the middle of the lateral mass. There is no lateral angulation. It is in the lateral radiograph fluoroscopy. It is perpendicular to the facet joint and purchases all the 4 cortical surfaces. Unlike a lateral mass screw, which purchases only 2 cortical surfaces, this one, because this is very biomechanically stable, because it crosses a joint and purchases 4 cortical surfaces, which means it has a greater pull-out strength. Now, this is after exposing the posterior aspect of the cervical spine using a small osteotome, the facet joint is entered, and by a ribbling movement, you can curate the facet joint. You can take the spinous process, crush it, and push it into the facet joint. But what happens is all the bone chips that go in will not remain there, because when we drill and tap, some of these chips will come out. So it might be necessary to place some of the chips on the lateral mass after the instrumentation is over. Then once as you can see, the drill has crossed all the 4 cortical surfaces, the joint, and purchase all the 4 cortical surfaces. This is followed by tapping, which was also on the same trajectory, and followed by screw insertion. I'll be showing a video later. Now the exit point of the screw is very important. People generally, when they talk about screw fixation, they talk about the entry point. Nobody talks about the exit point. The exit point, there are specific exit points for a lateral mass screw, and there are specific exit point for a transfascial screw. The ideal exit point for a transfascial screw should be what is known as pre-zone 1, as shown by the red arrow. Now, this is one of the earlier cases where I had planned to put 8 screws, ended up putting only 4 screws, because I used the Takayasu's technique on one side and the Delcanto's technique on the other side, and I ended up fracturing many facets. So by studying the postoperative scan of these patients, I decided to change the technique. And these are the postoperative images of the patient I showed earlier. These show the lateral angulation of the Delcanto technique and the no angulation of the Takayasu technique. And now this is one of the patients with the cervical myelopathy, where we started using our technique. And the technique involves entry point 2 millimeters cranial to the middle of the lateral mass, perpendicular to the facet joint. We use the classical 4mm screws that are used for the anterior cervical plating. And for an average Indian adult, generally we use a 16mm, or occasionally even an 18mm long screw can be used. Whereas for an average lateral mass, we'll be able to use only a 14mm long screw, which means not only it is much more biomechanically stable. And these are the postoperative images which show there is no lateral angulation and the lordosis is maintained. And this is the postoperative parasagittal CT scan which show the screws passing across the facet joints. And this is another patient with the multi-level cervical myelopathy. But this patient, you see, there is a mild kyphosis because the line joining the posterior aspect of C2 to posterior aspect of C7 crosses the vertebral bodies here. But it was a reducible kyphosis, which we assessed by X-ray. So improperly, we positioned the patient to restore the lordosis. And we ended up doing this. This is on the image on the left side, shows the screws across the transfascial screws, followed by a laminectomy. And the image on the upper image shows the postoperative radiograph, which shows there is no lateral angulation and there is restoration of the lordosis. The images lower show the facet screws crossing the facet joints. And another example of a patient with the multi-level cervical myelopathy with severe cord compression. And this patient has a preserved lordosis, and we did the same procedure for 4-level procedure. The lower end is C2, the upper end is upper image part of the image is C7. This is where we did a laminectomy. And those are the post-op images which show the restoration of the lordosis with the screws across the facet joint. Now, this is another post-op CT scan of that patient showing these screws crossing the facet joint, all the screw tips in the ideal exit point known as pre-zone 1. On the posterior image of that particular patient showing the posterior shifting of the cord, preserved cervical lordosis, and well decompressed anterior and posterior subarachnoid spaces, anterior and posterior to the spinal cord. Now, this can be unlike, as I said earlier, in laminoplasty, if you use a lateral mass screw, because the direction of the screw is laterally, the tulip head of the screw will be medial, close to the laminar facet junction. So when you open the lamina it cannot be opened fully because of this medially directed head of the lateral mass screw. Whereas here it is possible to do that. And this is what we have shown here. We have because the screw head is flush with the bone, it is possible to combine it with the open door laminoplasty. And what we do is we use a dental drill to go through the spinous process, pass a non-absorbable thick suture, and we leave on one side, we leave the last 2 threads. And then once we pass the suture around, we tighten the threads tighten the screw so that the laminar door remains open. And that's the post-op image which shows the transverse screw and the open laminar door. So we have achieved. One of the disadvantages of laminoplasty is that it is prone to develop kyphotic deformity over a period of time. But if we do this procedure, we are stabilizing as well as preserving the posterior elements and as well as enlarging the spinal canal. That's the pre-op and post-op. Notice the change in the cervical alignment, pre-op and post-op, as well as the posterior shift of the cord and the opened anterior and posterior subarachnoid spaces. Now, this does not come without a cost. This is one of the early images which I showed, the case where the facets were fractured. We studied these post-op images and realized the facet fracture occurred because in Takayasu and Delcanto's technique, if you use this entry point here, the bone mass that is available between the entry point and the lower margin of the facet is very small. So what happens is there's a risk of breaking the facet. So to avoid that, we shifted the entry point 2 millimeters above, and instead of lateral angulation, we kept the angulation straight so that you can pass a longer screw so that a better pull-out resistance can be there. But there is one disadvantage. If the patient is going to be very obese or has a short neck, or if the patient has a very prominent occipital protuberance, you can place screws in C6, C7, C5, C6, but especially C3, C4 becomes very difficult. Sometimes even C4, C5 will become very difficult. It can be done, but we have to compromise on the lordotic cervical alignment, which is not a great idea to do. So just to conclude, I'll just show you a brief video after the PowerPoint presentation. Transfacet screws have more pull-out resistance. They have been shown by several studies to be biomechanically superior, and 80% cost is less than, because we are just going to use a routine anterior cervical screws, the cost is 80% less than a lateral mass screw. And because of the low implant profile, as I have shown earlier, it can be combined with the open door laminoplasty. And this summarizes the advantages: biomechanically stronger, cost-effective, and simple technique. Not very. Once you become familiar with the technique, the radiation exposure to the surgical team and to the patient can be significantly reduced. Can be combined with the laminoplasty because of the low implant profile. But of course, there are certain shortcomings, such as the difficulty to instrument the upper levels in a patient with a short neck. Now, let me just stop sharing this and show you a brief video. So this is the posterior aspect of the cervical spine is exposed. This is C2, this is C7. We choose the middle of the lateral mass, middle of the facet, and use a small dental bulb to make a entry point, because if you directly introduce this, this drill, the drill will sky off and break the facet joint. So we use a drill, we use a 2 mm bar to make a perforate the cortex and then drill it under radiographic control. Once after the first few cases, you will know the trajectory. And if you can see very carefully, the upper facet and the vertebra keep moving when you are drilling. But once the drilling is complete, the movement between the two, the upper vertebra and the subjacent vertebra, caudal vertebra, will stop because we have crossed the facet joint. Actually, what I ask is, I ask my assistant to use 2 tower clips to hold it, so we can also feel the resistance, give way of the resistance when you cross the facet joint, and the assistant will also feel the reduced mobility when this the drill crosses the joint. But in this photograph, in this video, I have not, because it hides the line of vision, we have not done that. And this is followed by tapping. Generally, we talk for 16 millimeters. Certain cases, it is possible to pass a 18 mm screw also. And as you can see now, the movement between this vertebra and this vertebra will cease once the facet joint is crossed. And there will be a give when you cross the facet joint resistance, and this is the tap. This is followed by screw insertion. Generally, use a 4 mm screw. A 4.5 mm screw is usually used as a rescue screw, but most of the time you won't have to use a 4.5 mm screw. This is how it is done. I will just stop sharing and then I'll tell you now. This is the earlier version of doing it. For the past year or so, I do it in a different way. What I do now is, now that we have a self-drilling screw system, I use a 2 mm. I am not shown in this video. I don't have a video of that. I use a 2 mm dental drill. Directly pass the drill through the facet joint across the 4 cortical surfaces, and then follow it up with the directly without tapping. Use a self-drilling screw to pass the screw. So that way it reduces the radiation exposure, shortens the operating time. Thank you for your kind attention.
Thank you, Muthukumar. And now we'll go for the discussion. I'll hand over to Dr. Apurva, please.
Before that,
Sorry,
yeah, continue, Apurva.
I request Dr. Goel and Dr. Modha to kindly comment on the lectures and please give their opinions.
Thank you. My question to Dr. Atul, I will start with Dr. Atul Goel's paper. Atul says that he don't believe in anterior screw for type 2 oriented fracture. I think this is the simplest and shortest procedure which can be done anywhere in middle size city or town. So compared to his posterior procedure, type 2 oriented fracture, anterior screw fixation is ideal. Atul.
Yeah. See, the advantage of anterior screw is that you retain the mobility of the T1, C2 joint. So, you know what, that is one argument, and I used to do anterior surgery earlier, but I have completely abandoned because I'm much more familiar with posterior C2, and my issue is, anterior surgery is, you're saying it is very easy, but it is, it has several issues, and it can have several issues.
Yeah.
You have to agree.
Yeah.
And posterior surgery, in my calculation, is far more straightforward and simpler and solid and final.
But longer time. It takes long time compared to the anterior things.
And patient will also live long.
That's equal for both.
No. I can say that I like posterior. Maybe there are some arguments for and in favor of anterior. And that is your personal opinion. If you find it simpler, if you find it solid, and if you have got good results,
Yeah,
I think one must go ahead with whatever you think is the best.
yeah.
So-
Thank you. So,
Can I have one question for Dr. Muthukumar?
Yeah.
Sir, in transvertical screw, how would you like to preserve the vertebral artery means and that the trajectory?
Pardon?
How will you preserve the vertebral artery?
That
in
is
the transvertebral-
one of the advantages of this particular screw technique. Unlike a lateral mass screw, if a lateral mass screw is not sufficiently directed upwards and laterally, you will end up in the transverse ferment, right? The direction, the trajectory of the screw is there's no way you can enter into the vertebral artery unless you direct it laterally. If you use the Del Cantos technique, there is a chance of injuring the vertebral artery if you cross the cortex, right? If you use this particular trajectory, the trajectory which I have described, it is a straight trajectory. And as you pass the first cortex, you have the cortex, cancellous bone, cortex, joint, there is a give way, and then there is another cortex, and then you will feel it. The trajectory is well away from the vertebral artery. The vertebral artery will not come in your way. Touch wood, so far, it has never happened. And even in lateral mass fixation, at least touch wood, I have not injured the vertebral artery. Of course, during C1, C2, I have done it, but not in lateral mass or in transfacet.
Okay.
Muthukumar, I have one question. By putting these transarticular screws, is there any restriction of the cervical spine movements?
There will be a mild restriction of the cervical spine movement, definitely, but it is the same as you get with the lateral mass screw fixation, because any screw fixation of the facet joint, whichever way you fix it, whether you use a lateral mass or a transfacet, there will be some restriction of movement. That is bound to happen. But so far, no patient has complained it to that extent that it has interfered with his or her personal or professional life. It is not to the extent that we see in actually the rotation limitation, which we talk about in C1, C2, except for very few patients, not many patients complained about the rotation, limitation of rotation in C1, C2. And I'm sure Atul and Praveen will agree with me. There are some patients who, for occupationally, it is definitely a restriction. I don't deny that. But practically speaking, it is not much of a disability to the extent it has been portrayed.
No, I can, Dr. Moda, I can, completely agree with what Dr. Muthukumar has said. That transarticular fixation, this Camillus technique, is a fantastic fixation technique. It is safe, it is strong, it is quick, and it is absolutely, I have written several articles on this where we are reporting 100% results. Means it is a fantastic technique. Facet is the strongest bone, even stronger than pedicle, much stronger than body, much stronger than transverse process, spinous process. Facet is the strongest bone. So if you can use the strongest part of the bone at the fulcrum of all movements are occurring at the facet. So you are using the best bone. You are using one very simple, straightforward screw, much cheaper, much stronger. I think there is no question in my mind that this is the technique of interbody fixation. Now, if you are going to fix interbody, there has to be some restriction. And if you are going to use multiple levels like what we have seen, then there will be certain restriction. And this is the price you pay for any kind of fixation, whether you do it from corpectomy and fixation or from behind or what. I think this technique is here to stay and here to go further.
Yeah. May I make a comment?
Parthiban sir, there are three delegates which are asking the question, similar question. For lock facet and cervical spine trauma, role of methylprednisolone, are you recommended it? Very debatable, but your opinion.
You asking me?
Yes, sir.
Okay, see, I tell you about the WFNS because I was in the group and we had a lot of discussion about this. And even American Association has changed its mind. There was a blanket view that methylprednisolone should not be used. for a long time. But now that concept is not there. If you can use judiciously and choose the patient, the right patient. For example, young patient, isolated cervical spine injury, no comorbidities. In these patients, we have to give the benefit of what the laboratory has told us. So methylprednisolone can be used in patients of these conditions. I'm talking about an isolated cervical spine injury, no comorbidity, young patients. And please make it clearly. And if you can see in the literature what we have written in the WFS spine recommendations, this is what, including Michael Felling's group, have approved this. The prior, that's about 7 years ago, they were very blanket all over the world that we should not use because of the high rate of complications. When we have a multiple injuries, like, in cervical spine, head injuries, thoracic, in combinations, then they don't do well. So isolated cervical spinal cord injury, you can choose that. This is my opinion. I don't know about the other group. And this is what we have come to conclusion.
Dr. Joseph, you are also using in the CMC Vellore steroid in the spine?
No, we are not using.
Yeah.
I think, Dr. Parthiban, that is also option, no? You can use if you want to. Isn't that the guideline?
Yeah, this is the guideline right now.
Not that you have to use it.
You see, this is what I'm telling. What I'm now telling is the last guideline. Please go to the literature and see the last 7 years, what the same group, Michael Felling group from AVO Spine, they also have concluded this one. And in the WFNS Spine Committee, where we did a consensus meet on this, we came to this conclusion. Isolated spinal cord injury, young person, no comorbidity. That's all.
Thank you. Thank you all. Because of lack of time, we will again come to discussion after panel discussion. Dr. Apurva, please introduce the panelists and start the case discussion.
Thank you, Dr. Jayesh. I would like to introduce the panelists once again. We have Dr. Raghavendran, Dr. Balamurgan, Dr. Vinu V. Gopal, and Dr. Guneet Sawhney. I would just share my presentation of the cases, and we can then start with the discussion. We would have a quick discussion on all the cases for maybe 5 minutes, and then we can just conclude this webinar.
Right now, we have 92 viewers on live with us.
I hope my presentation is visible.
Yes, it's visible.
Yeah.
So this is the first case. I'll just give a short history and the. So this is the first patient who's a 26-year-old male. These two cases have been given by Dr. Ramesh, who is from JIPMA, and I thank him a lot for the cases. So a 26-year-old male who had a history of fall from 8 feet. At the time of admission in the casualty, he was ACR grade A, with the power in the upper limbs grade 2 and the power in lower limbs grade 0. And these are the images which have been provided. And the images reveal C6, C7 subluxation with a bilateral facetal subluxation. We have the sagittal CT images, the sagittal MRI images, and the axial CT images. And I would request Dr. Balamurgan to kindly comment on the management of this case. Dr. Balamurgan, please.
Yeah, thank you. Thank you so much for having me on the panel, and all teachers, good evening. I think it's a tough case to handle. I would request, if possible, for more neurological things, including what is his respiratory efforts, because we can see there's cord edema and also extending all the way up to C5. So we would need to assess his respiratory effort as well. Now, given that if the respiratory effort is good, early 360-degree stabilization is what I would suggest for this patient. So initially anteriorly, discectomy, try to reduce it, and then go posterior and then flip back anterior. That would be my approach for this patient.
So would you like to use any traction for the patient when you're doing it?
Yes, intraoperatively, yes, under traction only, sir.
I think that would be the
And,
ideal thing. Otherwise, reducing this is going to be very difficult, because if we see the CT scan, the anterior margin of C6, the posterior margin of the body of C6 is wedged at the anterior margin of C7, and there has been a teardrop fracture also. So it's going to be quite tough to do this without traction. It will be almost next to impossible.
so what would be the perioperative management for this patient? Would you like to immobilize the colon, and for how long? And what are the parameters you would assess while the patient is recovering?
Yes, 360-degree stabilization. I think a soft cervical collar should be enough, but I think we'll have to explain to the patient about the respiratory problem. I think that's going to be the key. And maybe managing his respiratory thing will take precedence over anything else in this patient.
Dr. Balamurgan.
Yes, please.
How will you reduce? What technique will you use for that? Means first discectomy and then you will try to reduce it, or immediately on the posterior?
I think immediately posterior we will not be able to reduce. As I said, the wedging of the posterior border of C6 with the anterior border of C7, it has come down by a few millimeters. So with traction also, I don't think we'll be able to go first posterior in this patient. We may have to do a partial corpectomy of C6, and that will help in reducing. With the Casper, we'll be able to reduce a little bit. Then we may have to hold it in that position, flip him, do the posterior, and then come back anterior for the final fixation in the anterior.
So posterior will not put a lateral mass?
Yes, but I may be wanting to do 2 level above and 2 level below. So C5, 6, 7, and T1 will be what I'll do.
I mean, while doing posteriorly, you will put a lateral mass screw. Which level to which level? Will you do posterior fixation, right, in the second stage?
Yes. So that will be 5, 6, 7, and T1.
Okay, fine.
Dr. Venugopal sir, would you like to comment? Would you like to do something different? Or
how much is the duration of the injury? Any idea regarding the duration? Is it a chronic thing or an acute?
This is an acute injury. The patient was brought to the casualty within 2 days.
Yeah. He's having Asia scoring system. Yeah. So he's having a complete injury along with involvement of the bladder also.
Yeah.
So whatever we do, the functional impairment, we can't achieve anything with the functional impairment. Just we need a stabilization. It's a high grade dislocation. So initially I will go for a 360-degree fixation just for stabilization of the spine.
The first anterior and then posterior?
Anterior initially, followed by posterior lateral mass fixation. If again reduction is not achievable, we should try to reduce with the posterior approach and again come anteriorly and again fix it.
And sir, if this patient presents acutely to you, would you start the patient on methylprednisolone as was being discussed?
So routinely we don't give methylprednisolone.
Okay, sir. Okay. Thank you so much, sir. We'll go on to the next case. This is a 23-year-old male with a history of fall again from a height of around 4 meters, presented acutely to the casualty. The vitals were normal. This patient was an HDR grade C with a better power in the upper and lower limbs of grade 3 and grade 2 respectively. The imaging revealed a compression fracture of C5. It was a burst fracture of C5 vertebral body with a posterior subluxation and severe cord injury. So these are the sagittal CT scan images, and the MRI shows a body edema with the cord changes. And these are the axial cuts, which show the fracture of the C5 vertebral body. I would like to request Dr. Sawhney, if he is there, to comment on the management of this patient and his plan for treatment.
Yes. Thank you. Am I audible? Thank you.
Yeah, you're audible, sir. Please go ahead.
Yeah. Thank you, Ramani, sir, Dr. Jayesh, Dr. Apurva for allowing me here. Now, the first thing that I would want to say is that we can see that the cord edema is going up till C3 and a little above to the disc space. So we need to know that what is the single breath count of the patient. So that is very, very important. Everything of our depends upon how is this patient doing. Now, this is an incomplete injury. Our idea is to preserve this patient completely so that he becomes better. Now, for me, if we are taking that the patient is having a good single. If the patient is having a good single breath count, and we can see the power of the patient. So I will start the patient on methylprednisolone and then take the patient for surgery, which will be a corpectomy at C5 and stabilization directly. So this will be only an anterior approach for me. Corpectomy and then C4 to C6 anterior stabilization is what I would achieve. Now what I will do. Now there is a little catch on this, which I can see posteriorly. We can see here that there is a small fragment going inside. Now we need to decide whether to go posteriorly and remove this off and then do a stabilization. Now that will be decided about how is the patient condition. So this fragment which is going inside and compressing the cord is something which is of worry and needs to be seen on. Then we'll have to see this. So that is what
Dr. Sawhney, as you commented, this is a 3-column injury involving the posterior column as well. So for you,
Yes,
anterior surgery would be all that you would initially do.
Pardon me, I'll do the anterior column first. No, so the corpectomy first. That is the anterior. Yes, that's where the anterior approach will be the first approach which I will do.
Okay, thank you. Dr. Raghavendran, if I can have your comments, please, on the management of this patient, if you would like to do anything different.
Yeah, as already mentioned, there is an extensive cervical cord edema extending from C3 and almost up to the D2-3 level. And as the fundamental tenet that this cord has to be decompressed, which is already severely edematous, so that get some space. And we do not use steroids as far as acute cervical spinal cord injury is concerned. We have stopped using it almost several years ago, and we haven't restarted it. And it is, of course, a 3-column injury. But ideally, I would like to approach this first from the anterior approach. There is a clear-cut compression. We'll go ahead with a C5 corpectomy and stabilization from C4 to C6. And if possible, that should settle. And we'll go for a global fusion. We'll go for lateral mass stabilization, 2 levels above and 2 levels below. And of course, the clinical status, it says it is incomplete injury, but at the same time, we should look at whether the cough reflex is present, whether the patient is able to cough, because that is clinically the most important factor that decides the outcome of the patient, irrespective of the power and the limbs. So yes, I would do an anterior approach first and then go for a global fusion.
And while doing a posterior fusion, would you also like to do a posterior decompression?
No, sir. That depends on the post-op imaging. If the CSF column is seen well, both anterior and posterior to the spinal cord, I don't find a need to do a decompressive laminectomy or a laminoplasty in the posterior.
Okay. Thank you so much for your management opinion. We'll go to the last case. This was a 40-year-old gentleman. He presented with a motor vehicle accident. He was riding pillion on the motorcycle and he had a bad vehicular injury. He was Asia scale B. On presentation, he had bowel and bladder sensation completely gone. And this was a case of a polytrauma with a Jefferson's fracture and polytrauma to the face. So these are the MRI and the CT scan images. This patient data has been given by Dr. Goel, and I'm thankful to him. These are the MRI images. These are the CT scan images. The coronal and the axial views are given here, which shows the fracture segment running through the body of C2 as well. And these are the 3D reconstructed images, which clearly shows the Jefferson's fracture and the pieces of bone, which are just beside the dents, and the polytrauma to the face. So I would like to request Dr. Vinu Gopal to comment on the management of this patient.
Yeah,
A patient of polytrauma with Jefferson's.
Jefferson fracture. Usually, Jefferson fracture won't produce any neurological deficit, but here, as you can see in the coronal section, Here there is injury to the transverse ligament also, because as per the Spence rule, the overhang of C1 or C2 will be more than 7 millimeter here. So there will be atlantoaxial dislocation also in this case. So it will need a stabilization of the C1 and C2 joint also. I would like to get the opinion of Adil Goyal sir also in this case.
My opinion, let me just say, as you can clearly see, the fracture of the arch of atlas, and what happens is there is a lateral facetal dislocation. The C1 facet, if you see the coronal image, has gone lateral to the C2 facet, and like it happens in bifid arch of atlas. When there is a bifid arch of atlas, the facet, there is a lateral dislocation. In this situation, when there is a lateral dislocation, you can imagine there is a dislocation of C1, C2, and you are seeing on the images some instability at C0, C1 also. But this patient will need just C1, C2 fixation, and that's it. Don't ever, I don't ever do occipital inclusion of occipital bone in the fixation construct, because I am completely sure from my cadaver days experience that you cannot just break the ligaments of occipitocondyle, because they are as strong as steel. You can break your knife, you cannot cut those ligaments. So these ligaments are impossible to break. So C1, C2 fixation is the answer,
Dr. Balamurugan, if I can have your opinion on this and the management of the trauma to the face, how would you manage that in conjunction with the Jefferson's fracture?
You are mute, Dr. Balamurugan.
Sorry. So one thing which I would like to understand is what is causing his deficits. He's 0/5.
Yes.
And I think we need to have an angiogram. We need to know what is causing his such severe deficits. He's awake, but he is quadriplegic. He's pentaplegic, whatever. And what is causing his deficits? I think that is going to be very important before we really decide on what kind of management are we going to give and what we are going to explain to the caregivers as to what is going to be his outcome. Because if there is going to be a significant vascular insult, I think doing any of this is going to be superfluous. And he's anyway going to be bedridden. I think immobilizing him will be just as good as doing anything at all. That's my view. I'm sorry.
So in the event of a grave vascular injury, you would like to go for
I would just do conservative. I don't think I'll be doing. Yes, absolutely. I would just immobilize them, and I think we'll have to offer surgery, but I would not give too much of prediction as to prognosticate as to how well he's going to do post-op.
Can I make a comment? Can I make a comment?
Yes, Dr. Pathiban, please go ahead.
Yeah, see, it's very interesting discussion. Jefferson, as far as what we were taught in our education time, that is student time, was you don't need any surgery, it fused by itself. But here in this case, I'm sure that the most important problem will be the pain. If you ask me, there is a split, as Goyal was telling, there's a split. Then you always can put lateral mass screws of C1 and then compress it, right? You compress it, bring it down and immediately and tighten it. That's good enough. I'm not sure about to add it with C2. I'm talking about only C1. Only about C1. That is about C1 lateral mass screws, one screw in the lateral mass, another screw on this lateral mass, and then both together and then compress it. And you believe me that I think that will solve this problem as far as the pain is concerned, because neurologically, of course, the patient is bad. And the patient need to be put on a good collar. That's my view.
Dr. Muthukumar, sir, can we have your expert opinion on the management for this patient?
Thank you, Apurva. I think I'm just surprised that compared to the neurological status of the patient, the MRI looks pretty clean to me.
Exactly, yes, sir.
MRI looks pretty clean to me, and then I'm surprised to what accounts for his neurological deficit. I do agree entirely with Atul that there is a lateral subluxation of the C1 facet or C2 facet. And but what is bewildering is that the MRI looks pretty clean. So what is the reason for his neurological deficit? For a patient with a grade 0, I expect some change at least in the T2 weighted images. I don't see that. And all you can see is because the severe nature of the injury is very severe, because you see a prevertebral hematoma here, and there is a posterior ligamentous injury, which means there is obviously 3-column injury. So, and that is fine. And there are reports in the literature where some people very aggressively, as Parthiban has pointed out, put a screw here on one lateral mass, put another screw in the another lateral mass, do nothing to the C2, and compress the screws, and in the compressed position with the facets aligned, they put the rod and screw it in place. So that is fine. But only issue is now what accounts for the neurological deficit. Second thing is, if we do that particular procedure which I just described, what will happen? There is, if you look at the axial image, there is some avulsion of this particular lateral mass. The ligamental attachment here is avulsed. So this avulsed fragment, when we compress, will the avulsed fragment go and compress the cord laterally? That is a sort of worry. But before putting my knife on this patient, I would like to know what causes the neurological deficit, because as far as I am concerned, this MRI looks pretty clean to me, unless one of you is able to point out something, because I'm pretty clean in the sense that in the spinal cord, there is of course a prevertebral hematoma, there is of course a significant posterior ligamentous injury, which indicates the injury is very severe. But why it is so clean? Why the patient has a grade 0 power in all the 4 limbs?
Yes, sir. Dr. Salunke, if I may have your comment. Dr. Salunke?
I guess he's
on mute or not?
Apurva.
Yes, sir.
There are a lot of questions.
Yes, sir. So now we'll
open for all.
Yes, sir.
Sachin Borkar from Delhi is asking about the first case. It said that it is a SIA. If it is get reduced by traction only, will anyone consider only anterior approach, as this patient is unlikely to walk, or there is a minimal chance of neurological improvement? So any panelists want to take this question?
Shall I tell you? Shall I say I'm very clear about it, right? The 360 degrees so anterior posterior it is overrated. It is superfluous. We have done so many of this type of cases with very good anterior stabilizations. You don't need much again posterior. You believe me that if you put a very good plates and very good grafting with iliac crest graft, I usually use iliac crest graft in trauma patients, because the fusion is quick, very fast. And believe me that about in 2 months' time, 1.5 months, 2 months' time with a good construct, you don't need any posterior approach at all. Maybe I think that I can show you so many cases they done 30 years ago.
Means are you talking? Yes.
If it is when it is reduced. The question is when Sachin said when it is reduced. When it is reduced, I would like to do a very good anterior fixation. I will not go for posterior, because patient is grade 0. It is not going to help much, and you're going to give him a very good Philadelphia collar. That's good enough for a very beautiful fusion.
Dr. Balamurgan?
Yeah, as I was discussing the case, highly unlikely it's going to reduce. There is a teardrop fracture of the lower vertebra. The posterior margin has come and wedged with the anterior margin. Highly unlikely it's going to get reduced by traction alone, even under anesthesia. Yes, the patient may not walk, but who are we to say that? I think he's only about 26 years old. So I think we should give him the best of this thing. I think 360 degrees would be ideal. Well, if there is constraints with cost and other things, yes, we should explain to them. But youngster, I think we should give them the best possible.
Question from the Dr. Rajesh Tiwari from Thane. What is the dosage and schedule for methylprednisolone if used? So I guess everybody is following same 30 mg per kg bolus dose, and followed by 5.4 mg per kg per hour over next 23 hours. Anything for what I said, any change of opinion by panelists and chairpersons? Or
I think this is the NSSA 3 protocol, which we all follow. And I think that is pretty much standard, Dr. Jayesh.
Sometimes somebody, in chronic case, some use 500 straight during surgery,
sir.
and after that 500 or 1 gram every for 3 days. That's why I'm asking. Any change in the protocol, or everybody using the same? Sir, are you using the same?
Excuse me, I'd like to talk about Dr. Wise Young here. Dr. Wise Young, who was involved in this research, he made very clear, because he was involved in the ping pong in the NSSA 3 when they devised this, the so-called 30 milligram per kilogram body weight within 45, then you leave it for 23, 5.4 milligram per kilogram body weight, was decided on scientific basis. Anything more or less does not work on the cells. So that is why they came to this particular dosages.
There are two situations.
Tell me.
One patient came with a cervical trauma. Another situation in which even after a chronic dislocation or chronic spine trauma, we are operating, and during surgery, we are thinking or we are assuming that there may be a spine cord injury, and we are, prophylactically giving steroid. What should be the dose for that?
Okay, see, that's a pretty controversial. Every one of us have a different view on that. Unless you really create an injury there, you create it and then you treat it as an acute spinal cord injury. No. Otherwise, I don't think you need high dose of steroid for that particular, the so-called, prophylactic.
Goel sir, your opinion?
Unmute, please.
I don't like steroids. I don't give steroids. Whether, whoever likes to give should give and must give, but I don't give. Yes.
You see, the point which is making is, why do we need to have that feeling that we need to give prophylactic? That means, are we doing very aggressive way of decompression? That's all my feeling is. So you don't need to give. I don't give steroid when a patient comes a little delayed. We hardly give. That's why I made this statement that unless you feel that you have created an injury when you are during the decompression, then you consider that as an acute spinal cord injury, secondary again. Then you think about those dosages. So otherwise, no.
Okay.
I would just like to ask Dr. Muthukumar, sir, in your presentations, you have shown the decompression which you do after the fixation. So in chronic cases of myelopathy and in OPLL per se, do you use neuromonitoring also while doing a decompression in these cases?
Yes. For the past 8 years, I have been using neuromonitoring. Before 2015, I didn't have that access to that facility. After 2015, I have started using neuromonitoring. And that has certainly helped. I would say that there have been a couple of occasions, especially the OPLL, when there was not an electrophysiologist available. When a technician was doing it, there was some false positive because we have not done much. And then while we are closing, suddenly the technician told us that he is not able to elicit the MEPs in the lower limb. But when the patient woke up from anesthesia, he was pretty intact. But there's a couple of occasions of false positives which really, push the team in a lot of stress. But for that occasion, I think you need I stopped using a technician for these monitoring procedures. I use only an electrophysiologist. If I don't get an electrophysiologist, I have only one electrophysiologist with me, who comes from a different city. But if he's not available, I will proceed without IONM, but not with a technician. Because I have had one false negative, two false positives, which is really bad.
Okay, sir. And sir, at the end of the laminectomy, the usual practice is to see whether the dura is freely pulsatile at the end of surgery. So how does that really equate into a good patient outcome is what I want to know, sir.
This pulsatile dura, we have been taught that pulsatile dura at the end of surgery is a good sign. It is very, very difficult to quantify the pulsation. It's very difficult to quantify the pulsation. There have been many occasions when my junior colleague who assists me tells the pulsation is good, the dural pulsation is good, but I have not been able to observe this pulsation. So it is a quantitative, it's a very subjective thing. But as long We have been taught that if there's a dural pulsation, that it is a good sign. And in this context, I like to tell you, I have not done it. Let me first put it, I have not done it. I don't propose to do it in the near future also. In the Asian Oscillation Congress in Israel, in Jerusalem last September, there was an excellent presentation from UK, where there is a study going on where they have, for all patients with spinal cord injury, where they have done a posterior approach, they have done a duroplasty. And they measure the intradural pressure before and after before and after duroplasty, and they have also shown the improved spinal cord perfusion after that. There is some degree of relationship to a positive outcome. This is just in an academic context. I don't do that. Okay, I don't do a duroplasty, but just to keep things in perspective, that this is something which has been coming on, and I believe there are a couple of trials going on in European centers with respect to this.
Thank you, sir.
So, Dr. Ramani sir, Apurva is there? Ramani sir is there?
Yeah, he's there.
He's not seen.
No, I'm not. I can't see him. I think he has
disconnected. Yeah. Moda sir, bataiye.
I want to tell you my experience about the pulsatile dura. That pulsatile dura is a good sign of decompression. But how it will neurologically recover, it's very difficult to say. Atul.
A very difficult question you are asking me, my dear Prakash. I don't know whether you have read my recent work, but I have completely abandoned these decompressions.
Mm-hmm.
I look forward, Jayesh, to give my presentation on this subject, which I have been given all over the place. Maybe sometime, maybe next time, I like to give what I think and what I published quite heavily. More than 100 articles are there in the current literature where I have published this concept. And next time, maybe, Jayesh, I can say what I have to say to Dr. Moda and to all of you.
Okay, sir. Sure. So, it's all 7:45. So, Ramani sir's final comment was awaited, maybe a network issue. So, on behalf of Neurosurgical Spine Society of Association, would like to thank all the chairperson, Goel sir, Moda sir, all the speakers, respected panelists, Dr. Gurneet Raghavendra, respected Dr. Balamurgan sir, and Dr. Vinu Gopal, my friend. Thank you so much. I would also like to thank Dicin Pharma for the financial support for this webinar series. And thank you so much and good day to all.
Thank you and good night.
Thank you so much. Thank you, everyone. Thank you.
Thank you.
Good night.
Thank you, everyone. Thank you so much. Thank you.
Nice meeting all of you. Thank you very much.
Bye. Thanks.
Atulji.
Yes, good.
Thank you.
Atul, I'll tell you one my more experience, not about this trauma, but about C1, C2 compression and posterior fixation.
Yeah.
Recently, actually, I studied and I was so amazed, Atul, that I tried to salute you because 6 months ago, I have operated C1, C2 with syringes. And I was not expecting any miracles, but stabilization was good. But after 6 months, when I did MRI again, there was a lots of almost syringes has disappeared and patient has improved, practically become a normal. So
very good. You can give
I agree with your hypothesis.
half your surgical fees you can give me.
Yeah. But I was so happy. So I said, I must talk to you about disappearing of the syringes after C1, C2 fixation.
Tomorrow I am giving one Journal of Neurosurgery webinar at 6:30 p.m. I wish you can join at 6:30 p.m.
Definitely.
Journal of Neurosurgery. You can get on the, neurosurgery.
Can you send me the links, please?
Yes, I will send you.
Okay. You send me a link, Atulji. We'll join.
We'll definitely.
Okay. Okay. Bye-bye.
Thank you, Atul.
Bye-bye.
Good night, everybody. Jayesh, Parthi.
Thank you. Thank you, Jayesh. Very nice.
Thank you.
Good, well done. Thank you. Bye-bye. Bye.
Bye. Thank you, Gurneet.
Bye,
Gurneet,
Gurneet.
thank you.
Thank you, Jayesh. Thank you so much. Thank you.